Welcome to SDHC's Health and Wellbeing podcast. Before we begin, we want to emphasise that the information shared in this podcast is for educational and informational purposes only. While we strive to provide accurate and up-to-date content, it is not a substitute for professional medical advice, diagnosis or treatment. Always seek the guidance of your doctor or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Remember, your health and well-being are invaluable, so prioritise consulting with a medical professional for your personalised care. Hi everybody, you're listening to the Health and Wellbeing podcast from South Downs Health and Care with your host, Dr. Nick Harvey. The purpose of this show is to help people understand how they can help themselves and others with their health and well-being. Every episode, I interview an expert to understand the latest evidence and advice on how to improve your own health or help others. This month, I welcome Kayt Blythin to discuss deprescribing in Frailty. Welcome.
Hi there.
Kayt's career began in human resources and training services for companies like Tesco, British Aerospace and Social Services in Wales and England. Working with employees with health conditions and managing treatment side effects led her to an interest in pharmacy. She later earned a pharmacy degree, completed a postgraduate diploma and qualified as a non-medical prescriber. Starting as a pharmacist in Llandudno, North Wales, Kayt moved to Sussex, working over a decade with older populations in seaside towns. Initially visiting patients at home, her role evolved to supporting care home residents, focusing on medicine review and optimisation. Deprescribing is a key part of her work, emphasising that not all medications are lifelong necessities. Collaborating with National Health Innovation Service, she trains the network polypharmacy programme, advocating for proactive management of polypharmacy. So welcome again, Kayt. Thanks for joining us to talk about deprescribing in frailty. I'm fascinated that you had a career before pharmacy as well, because a lot of us don't. We're just kind of tunnel visioned, and I can imagine that probably contributes a lot to how you work as well.
I think it does, in that talking to people is what I learnt to do first, and then I became a pharmacist, as opposed to many pharmacists who learnt their pharmaceutical knowledge and then walked into a shop and had a whole range of people to communicate with. So I think I do come from a different place. Yes. Increasingly, though, pharmacists are very well trained in communication and consultation skills. So, I might have had an edge, but I don't think I do any longer.
I mean, it is interesting you touch on that with pharmacists, because there's a real diverse opportunity of careers in pharmacy now, isn't there? And maybe, I'm not sure how much the general population quite understands how much pharmacists do now.
Yes, there is. And, there's less and less pharmacists going into a career in traditional community pharmacy. Hospital pharmacy is still there, and there's many pharmacists working there. But actually, healthcare professionals moving into becoming prescribers has been a game changer in terms of allowing us to use our clinical knowledge that we were taught and trained in, and we watched prescriptions being written, sometimes badly, and it's a great relief to be able to tidy that up and to bring in our own perspective and work alongside our medical and nursing colleagues predominantly, and how we all come with a slightly different approach and priority, but balance each other out.
You're clearly very diplomatic there, saying that prescriptions were sometimes written badly. That must have been the bane of your life.
Yes. Yes, it is. And I think, pharmacists like detail, they like accuracy. There's laws that govern how prescriptions should be written. And it's really difficult to explain to somebody at a counter who wants their medicine that you can't dispense it because the bit on the writing on the piece of paper is not legal. Mm-hmm. Yeah.
But we're gradually getting out of that world now.
We are indeed, so yes.
Hopefully that'll be a thing of the past. But I think there is a natural and probably good kind of conflict between kind of doctors and pharmacists, isn't there? And I think that represents it in the sense of the guidelines are often very black and white, aren't they? And there's a requirement on pharmacists to go by their guidelines. And then doctors are meeting patients who don't always quite fit guidelines, and it becomes quite tricky, isn't it? And maybe this becomes the subject of this conversation as well. What are your thoughts about that?
Well, I think it's a very grey world. The guidelines are only a guideline, I would say, as our mantra once we're working as a clinical pharmacist, making clinical decisions with individuals. So yes, you need to know the guidelines. You need to know your limits or what the boundaries are to a degree. But most guidelines are written for a single disease state, and most guidelines apply to people up to the age of 65. So in our area where we work in frailty is not necessarily about age, but there's a strong correlation. Guidelines become interesting or almost irrelevant because they're not going to be applicable, and they're not designed for multi-comorbidity, complex, frail, elderly people.
Mm-hmm. So we're already diving into the topic a bit, and I can see that by the look on your face, you're really passionate about this area of prescribing and of medicine. So what about it particularly interests you?
Well, I think what interested me is the number of frail people who have side effects or harm or potential harm from treatments where there hasn't been consideration about whether there's an end point to this treatment. That's really the kind of where the crux of it is. And I think, when we look at deprescribing, often it feels like a full glass of water edging towards the edge of a table, and it's on the brink of tipping over and becoming, a hospital admission of some sort. And we just motivated to get there before that glass of water falls off the table and make some changes there. So yeah, I think that's where the sort of the essence of where the passion comes from. It's great talking to people as well. I mean, in our service, we talk to patients, their carers in care homes, and their next of kins if they don't have capacity or they ask us to. So we have hundreds of conversations with these people. The decisions have to be shared. We feel that you can't just whip medicines off people. You can't just get out your red pen and put crosses through. It has to be a shared decision and a discussion. And actually that's where the real joy is talking to people, talking to next of kins who feel so frustrated sometimes that they've been just not knowing where to go or how to get a medicines review, and that, somebody in 85 taking 17 medicines a day just doesn't feel right, but how do you fix it?
Yeah. And it cuts to the heart of, as a doctor, our kind of Hippocratic oath, isn't it? It's first do no harm. And actually, there are a lot of people we're prescribing medications to because of good reason in the past that are no longer kind of justify the prescription, isn't it? But it's a huge thing in taking that away from somebody, isn't it? It's defining a time in their life too, isn't it? I think sometimes.
Yes. And that's the real tricky balance. I've spoken to people who've, I don't know, their blood pressure is falling, and I want to suggest they stop a blood pressure medicine, and they will tell me, but my Harley Street doctor told me it was lifelong. And it's like, that's quite a difficult place to then come to a reasonable decision because they have a very strong health belief that their Harley Street consultant knew what they were talking about, as they did within the context, of course. But, we all know that nothing is for lifelong, long term maybe, but not lifelong.
Absolutely. So I can see that you've gravitated towards this in elderly patients in terms of focusing on reducing their medication burden, because probably it feels to me from the conversation that if there was one thing you could do for most people in a care home that's going to benefit them, if you're a betting person, it would be to identify what medications are safe or actually best to stop. Is that a fair interpretation?
Well, I guess it is from my perspective. Yes. I mean, I think there's many things that we can do for our elderly, frail people. I think finding better ways to keep them engaged, stimulated and mobile is very important as well. And medicines might play a part in that, or deprescribing might play a part in that. Yeah.
I think a huge part, isn't it? Because some of the medications stop them being able to be as mobile, engage as much, can't they? So it's a huge piece of the puzzle, isn't it? I guess. So in this kind of topic, I guess, have you got any particular structure to approach it and dissect it a little bit?
Well, what I was thinking is that we can talk about sort of what frailty is. Let's just make sure that we're clear about what frailty is and how we can look at the body and see what's going on in a frail body. Yes. Some of the organology of it as to why medicine's handling changes and why there is that sweet spot in somebody's life trajectory where deprescribing becomes appropriate.
Mm-hmm, mm-hmm.
Yeah.
Yeah. So do you have a definition for frailty that you use?
Well, it's almost not the definition. It's not age related, and just because you have dementia, that doesn't mean that you're frail, or that or it's not necessarily about dementia. Yeah. I listened to a talk a few years ago by Dr. Walker, who was our well-known cardiologist. He judged frailty by the number of legs you had on the floor, he said, as they walked into his consulting room. If you had 2 legs, you might get your TAVI. If you had 6 legs on the floor, maybe you're not. So that's one way of looking at it. That's fairly simplistic. I think we have frailty measures, which is looking at a combination of disease states, of the 20 disease states it takes into consideration. It then looks at symptoms like dizziness, weight loss, cognition problems, and polypharmacy. It throws in some abnormal lab results, whether that's EGFR, anemia, that kind of thing, and disability. And we know on our GP systems that all gets put into a calculation which comes out with the Frailty Index score. So that's a measure. In practice, though, we're probably using something called the Rockwood scale most of the time, which is a 1 to 7 scale. And from about scale 4 onwards, you have limited physical activity. And a number 7 Rockwood is a complete dependency for personal care. So the Rockwood scale is a useful guide.
Yeah, thank you. I find it really hard to explain to people sometimes, what frailty is, because as you said, it's every single organ system involved, isn't it? It's the brain not working at 100% anymore. It's your kidneys not working at 100% anymore. Your heart, your lungs, your muscles, your bones. And I guess it's the summative effect of these tiny changes over the whole body.
Yeah.
And the other thing I find hard is when people say, well, they're not that frail. They were, out doing the gardening last week and, they're not that frail. Do you get that? How do you explain that? How do you bring the families along in those kind of conversations or the patient? Do you have any tips?
I think that's a hard one. I think if you are out doing the gardening, you're probably not that frail, quite honestly, because I think that's a really clear indicator of you are still functioning well. Yeah. So sometimes the complexity of comorbidities and the rate at which they come at, I think, can be really hard for families, and that people can go well into their 80s fully functioning, as it were, and still, participating in life and enjoying life. And then it takes one hospital admission and it feels like perhaps because we see it as healthcare professionals, we see that baseline drop and they're unlikely to recover it. And that's a really hard journey for loved ones and next of kins to see that baseline change and readjust.
And I think that's where I was coming from with the gardening point. So, because I often see people who were genuinely, coping at home, but it was almost a coping. They were doing their gardening, but they were functioning almost at 110% to do that. And because they were frail, not as frail as people in care homes, but frail to a degree, it took one hit of an infection or something to take them beneath that threshold. And there was a chasm that it looked like they crossed in their decline, but it was kind of reflective of the fact that they were pushing their system so far to cope prior. And it's really tragic to watch, isn't it? But sometimes you just see this massive drop.
It is, and particularly being bedbound for frankly, not even any length of time, even 48 hours is enough to change your baseline in frailty, in that your muscle loss and your ability to recover that muscle is quick, and then it's fast. It's difficult to recover. Yeah.
So I guess just thinking from a family or patient perspective, or even GP, we've identified someone who we think is a little bit frail. So what we're kind of saying in our conversation now is these are the people. Let's have a think about, what medications they're on, and are they needed? Are they potentially doing harm, or are they doing benefit? I guess there's two questions there, isn't there? Is there any next step that you kind of go? Are there any particular medications that you focus on, your first efforts on? What's your approach now?
So when I did the role visiting people in their own homes, which is an earlier phase of frailty, yes, we go back to maybe Rockwood 3, 4, 5. Yeah. It is looking at that person and what they're achieving, or where their vulnerability is at the moment, but also looking at them physically. So you're looking at some of their measures, like what their renal function is like, what their liver function is like, and also about some just non-negotiable aspects of aging that is going to be taking place. So we know that livers get smaller as you get older. They have reduced blood flow going through them, which means that the processing of medicines is going to change. We know that kidney function drops by about, 5%, if you were going to put it into layman's terms, or 7.5 mil per minute per decade, which means it's inevitable that your kidneys are going to become a less efficient filter. And that's another way of stacking up medicines. Yeah. So I guess that you're looking at the person and looking at, how they're functioning, literally physically, what their muscle mass is like as well. But in terms of looking at that first screening of a medicines list, then maybe you're probably looking at what's their falls risk. So what medicines are contributing to falls, what medicines are contributing to cognitive decline. So there's the anticholinergic burden, which identifies medicines that cloud your cognition, resulting in sort of a dementia-like cloudiness, but also a higher risk of falls. And we know people with a high ACB burden, as it's called, have a higher mortality rate. So those medicines would be, amitriptyline is probably our most common medicine that we would be stopping, that we see because it's used as a painkiller, but we will also work really hard to get that off somebody's prescription.
Any other, so these anticholinergic medications, so the cholinergic is something that comes from, I guess, the way in which some drugs are designed to work, isn't it, in terms of at the nerve level in the brain or somewhere else. And you mentioned amitriptyline. What are the other common ones that have this high anticholinergic effect that we should be looking out for?
Well, in very general terms, they're almost all the medicines that can get into the brain or affecting our brain function. So most of the antidepressants will have an anticholinergic burden, antipsychotics, old-fashioned antihistamines, promethazine is another one with a high burden. But often it's the accumulative adding up of drugs that you think are fairly innocuous, but they do have a burden score of 1, So lansoprazole, or the PPIs, they have a burden score. Metformin does, furosemide does. These are very common physical health treatments. They've all got a score of 1, and it doesn't take long to get to that critical score of 3 where you're starting to get some negative side effects.
Mm-hmm. I'm just listening to it. I think it must be quite bizarre for people that haven't heard about this before. I'm going to have a go at explaining it, and I'd like you to critique me if I'm wrong. So all drugs are designed to have an effect somewhere in the body, aren't they? And what I think we've found over time is that a lot of drugs also block these receptors on nerves called the cholinergic receptors, and they block them to differing degrees. And this is almost, in some drugs that's their design, and in some drugs it's like a side effect, isn't it? And so what I guess the research has found is that there's a whole long list of different medications that block that particular receptor in the brain and nerves to different levels. And the more of them you take, the more they're blocked, the more confused therefore people get, and the more unsteady they get.
Yeah.
Is that fair?
Yes, I think that's a good summary. And I think there's some really easy telltale signs as well, like these medicines, this anticholinergic burden side effects also include things like dry mouth. If you think about our flu and cold remedies, Lemsip, that's got a decongestant in it. That works by drying us up. It feels a bit like that. It's great when you've got a cold to be dried up, but it's really uncomfortable to have a dry mouth, dry nasal passages, a gut that feels dry, not being able to pee as much as you want to. When drying up happens everywhere and all the time, and not just when you've got a cold, then that's not so comfortable.
And so if somebody's worried they're on too many drugs, and maybe if I just take a step back, because we were talking before we started recording about whose responsibility is it to reduce medications. And I guess my brain is starting, well, to start with, I think people are empowered to ask about that, aren't they? So if we start with that, what would you advise people to do? Thinking, well, I'm on quite a few drugs, and what should they then do?
So what they should then do is talk to somebody who knows about medicines. What they shouldn't do is decide for themselves what to stop taking, because that can be really dangerous. And most of these medicines, this particular group of medicines, we would deprescribe by slowly weaning people off. So it needs a conversation. So that would be my first and foremost strong message. Really, any pharmacist will know how medicines work and can look at a medicines list and identify where your high side effect profile drugs might be sitting. And then access to GP services, whether that's a GP or a pharmacist working within a GP surgery, or any other prescriber, be it a paramedic, a nurse, will be a useful first starting place to have that conversation as to what might be less beneficial now, or causing some of these side effects.
Absolutely. And I guess some people might go, well, why isn't the person who's prescribing this telling me to stop it? You got any thoughts on that?
I think it takes time, these conversations. They're not quick. And most of our consultations with medics in primary care are about trying to fix an acute problem now. They're not longer, more in-depth conversations about a holistic review of all your conditions and all the treatments for those conditions. It takes time. But, and also you need to be willing to have the conversation as well as the patient. If you like your medicines and you want to keep hold of them, then it's hard for a healthcare professional to start that conversation with you, because you have to be on board with the concept.
Yeah. And then have the time, as you say. And I guess the difficulty from our perspective as GPs is that you don't know when people are entering that kind of frailty phase to you. And so the whole model of how healthcare works in this country is quite reactive, isn't it? It's, I've got a problem, let's treat that problem.
Yeah.
And so what you're doing in your service is actually flipping that, aren't you? And saying, let's proactively look at this group of people who actually might not need things. They're not complaining of problems, but we might be able to stop them having a problem or find a problem that they didn't realise is solvable.
I think what's unusual about our service is that we generally see people when they're well. So when we take a blood pressure when they're well, it can look very different from a blood pressure when maybe a GP or a paramedic is seeing them because they're unwell. So their blood pressure is either very high or very low potentially. Yeah. So even small things like that, having a medicines review when you're well, as opposed to when you're poorly is a better place to have it. And that's probably why they don't happen so much in hospital, especially with the ever increasing rapid turnaround time in hospitals. It's not a great place to have these conversations and deprescribing, but it is a great time to have it afterwards. And maybe that's where we all need to find time, is to do that kind of 3-4 week check-in to say, right, how are things now? And this is our opportunity.
Mm-hmm. So you mentioned blood pressure just there, because there's another group of medications, I guess, that you look at quite a lot.
Yes, we do. Yes. Not everyone's on a blood pressure tablet, I'd just like to mention, but there are lots of tablets that we do take that do affect your blood pressure. But the most commonly prescribed dementia medicines, both of them affect your blood pressure. Donepezil tends to push it up and Memantine tends to push it down. I hope I got that the right way around. I'm sure somebody will correct me if not. So generally, as people get older, because of that orthostatic risk of postural hypertension, of a rapid blood pressure drop, you want their blood pressure to run much higher than they would have been doing when they were maybe 40 years old. So, our standard adult blood pressure target is 130/80. In Frailty, it's fine for it to be 160/90. And there's good reasons for that, in that you're more likely to stay upright when you stand up and not get that kind of dizzy sway. Yeah. And that risk of a fall. So that's kind of where the blood pressure monitoring comes in, and why we ask every single resident to have their blood pressure taken and to be weighed as well. We do like a weight before we go and do our reviews.
And I think doing their blood pressure standing up is probably more important often, isn't it? Because I've come across a number of people who have got a high blood pressure sitting down, and everyone's trying to get that controlled, but actually stand up and it drops into their boots, and we need to be more aware of that, don't we? I think
Well, we do, and particularly with women. The women and men are different. I think we all know that, but pharmacologically, we're not very good at recognizing that they simply handle medicines differently for very good physical reasons. Men have a bigger heart, have a bigger stroke volume, so it beats stronger and deeper, and that's because it's driven by testosterone. Yeah, and it has less risk of going into a dysarrhythmia or an irregular heartbeat, whereas women's hearts don't beat as strong. And they have more risk of that dysarrhythmia. So, and that causes more likelihood of a drop in blood pressure. So simply by dint of your sex, you can be more exposed to side effects. And we know that's very well documented, that women have more side effects. And it's probably because we're using medicines that were designed on fit, young, healthy men in frail women who actually have a different way of handling some of the drugs, particularly the blood pressure and heart medicines.
Interesting. Any other drug classes then that you jump to?
Wow. Yes. I think analgesics is a really interesting area, and it kind of dovetails into the conversation you had before with the MSK team, the specialists. Analgesics accumulate in the elderly much more easily. So as your liver and your kidneys processing of medicines, all medicines have to come out one way or the other. They either come through the liver or they come through the kidney, and then eventually they exit your body. So either one of those organs or both is going to not work as well. And that causes medicines to stay in your body for longer and accumulate. And this is particularly true with opioid medicine. So morphines, buprenorphine, oxycodone, fentanyl that we very rarely use now. I don't see it often prescribed in the elderly. It's a high risk drug for those reasons.
Sure.
Yeah.
Sure. And that can be trickier to stop too, of course, isn't it? But equally important to look at. And you mentioned when we were talking a group of medications called antipsychotics. Do you want to expand on that?
So antipsychotics are medicines that were developed 50 odd years ago, probably, and they've been used to treat schizophrenia in very high doses. And even the doses for schizophrenia are much lower than they were 50 years ago. In dementia, sometimes there's a phase in dementia where people become agitated and aggressive, or hallucinate, or get very paranoid. So they're sort of like some of those psychotic traits that you have in early stages of schizophrenia, maybe, or unmanaged schizophrenia, but they're pretty low level. But the difficulty is that you can be a danger to yourself and to others, because you're very uncomfortable. It's that really difficult phase in dementia where you might be aware that that you're not as on the ball as you once were, and it's hard to manage. And the way it can be managed is through medicines. It's also really well managed through psychological behavioural changes and working with that person. I think all of us who work with people with dementia or live with people with dementia know that you can distract people, you can change the course of where their mind is going, but it takes time and effort, and sometimes you get it wrong. Yeah. Mm. So for some people, we prescribe antipsychotics. Yeah. So risperidone is the one that's most commonly prescribed at a very, very low dose. So it has a much lower limit on its higher dose. And it's licensed to be prescribed for six weeks, reviewed, and then up to 12. Although we find it being used for much, much longer. And it's a difficult medicine to stop because you don't want to live with the re-emergence of that aggression and that agitation and discomfort for somebody. But the side effects, the risks of being on these medicines longer term are well documented, and your increased risk of heart problems and stroke in particular dramatically rises. So we're very keen to challenge whether these medicines need to be continued. And anyone who is remotely involved in caring for somebody on these low dose antipsychotics used for those behaviours should be saying, can we have it reviewed? Do they really need it? Or it's made no difference, so therefore we need to stop it. It's not going to make a difference in 3 weeks' time. Mm. It's going to make a difference within a week.
Mm. Mm. Tricky one, isn't it? But there are very real risks to taking it too, aren't there?
Absolutely, yes. I mean, because of the risk of stroke, but also, it's another brain medicine, isn't it? So it's going to make you more vulnerable to falls, to getting your footing wrong because your brain is clouded and it's not functioning so smartly. So there's definite risks to it. Yeah.
So a lot of your job, it feels like, talking to you now, is almost balancing probabilities, isn't it? Probability of, on what are the chances? There's no number you can give that often of a problem versus a benefit. And I think it sounds like it's a lot of expertise and experience that feeds into kind of some advice on best probabilities, really.
Yes, absolutely. It is just that. It's trying to get the balance right. And it's a very dynamic area of healthcare as well. I think maybe we have a picture of people get shoved in a care home, for want of a better expression, and left there and forgotten. Well, I truly think those days are well and truly over. Mm. Care homes and people living in care homes are getting more support and more health interaction than they have ever had. And I think the very fact that we are doing these medicines reviews there and are challenging these prescribing and trying to keep up with the trajectory that person is on. And, that period of dementia when you are sort of distressed doesn't last forever. And it's really important to recognise that it stopped and we're through that phase and we can alter things again. And that it's accessible to do that. Yeah.
I think we've probably struck on some of the big groups of medications. I don't know if you disagree with me there. One of the ones left in my mind is statin medications. I guess. Have you got any other thoughts of other medicines that are common ones to look at, and what are your thoughts on?
Well, statins is a really good example. It's the most prescribed medicine in the UK, or atorvastatin is the most prescribed medicine in England. And it definitely has a role. Definitely. If you've got cholesterol that isn't where it should be, or blood tests are showing where it shouldn't be, and you're anywhere but, 45 upwards, then you should seriously be considering a statin, because it's now that you want that treated. Statins work by reducing the amount of bad cholesterol, which is going to clog up your arteries and potentially clot together and create a stroke or a heart attack or whatever, clot somewhere in your blood system. And it takes time to clear out that pipework. And once it's cleared out, it's going to take time to rebuild it up. So we do reach a point in frailty where you don't need your statin, because you have cleared out your pipework because you've been on a statin for 20 years or so. And frankly, there's not much prognostic benefit to staying on it, because you're simply not going to live long enough, to be brutal, to build up that amount of bad cholesterol again. So that's why we look at statins as to where somebody is in their level of frailty and how appropriate it is now, like whether preventative medicine really has a role any longer. Yeah. I can't think. There are some others. Alendronic acid is another one, which is the bone medicine, which is taken once a week. So most people know it by the once a week medicine. You have to sit upright. You have to have it before you eat any food or have any other medicines. You have to have it with a large glass of water. So this medicine, we know, has got what's called a really long half-life. It's in your body for 5 years at least, clearing its way through. It's very slow to leave your body, which means that we can stop it after you've had it for 5 years, because you've probably got enough in you to keep on functioning and helping you build bone once you've stopped it. So that's another one that is quite common. Yeah. And whilst I'm on the subject of my favourite deprescribing medicines, there's a group of medicines, PPIs, omeprazole, lansoprazole, also very, very commonly prescribed, often started because you had a muscle strain injury. So you were put on some ibuprofen or diclofenac. You then needed stomach protection, because we know those painkillers irritate your stomach. And then you're stuck on lansoprazole or omeprazole for the next 20, 30 years. We do a lot of deprescribing of that. It definitely has its place as a protective medicine, but you need to make sure that you're still taking all the other medicines that require that protection, or you have proper diagnosis of a GI problem.
Yeah, I think those lansoprazole, omeprazole, pantoprazole are medications that there are a small number of indications where you really don't want people to stop them, and a large number of people who don't need them. And I wouldn't want people to wait till they're frail to think about that one either, because there are, potential effects over time, aren't there, of using them.
Well, I understand that omeprazole has the most side effects ever documented of any medicine.
Is that right?
Possibly because it's so prevalent, and every something has happened to everybody out there. So yes, you look at the side effect list and you're almost certainly having one of them, I would say. So I wouldn't advise that. But yes, it does have some really serious side effects, omeprazole. It changes, or all of these medicines, it changes the acid level in your stomach. So your stomach should, for a healthy adult, is working at a pH of 2. And as you get older, we know that pH naturally rises, so it becomes less acid. Well, the reason why you want an acid stomach is it's your first line of defense. If you eat a bug, you want it to be obliterated by that high acid environment. So as you get older, that pH naturally rises, and these medicines also increase your pH. So it means that first line of defense is getting weaker. So that's one reason why we don't like it. And it also means that medicines don't get managed in the gut in the same way because you're functioning at the wrong pH. The other more serious side effects maybe is that it can change your magnesium and sodium levels, and that can cause a delirium, which is a horrible thing to go through, especially if you never needed to.
Yeah, absolutely. I always get a little bit worried with these conversations because then you think, oh, are we scaring people too that are taking them? And of course, these are actually tried and tested, very safe drugs in the grand scheme of things. But every drug has potential side effects, doesn't it? And we do need to balance the pros and the cons. And those pros and cons change as you age, don't they?
Absolutely. And I think that is the core of it, isn't it? Is that it changes, and it's not being static. It's not saying, it was the wonder drug. And it was the absolutely right thing when it was first prescribed. I mean, I think maybe what we do need to change in our practice is the initiation of medicines and thinking and helping our patients know that this isn't necessarily forever, that they can stop it, putting that end point in. It's really easy to do that with antibiotics. It's really clear. And we kind of all know the rules that you take antibiotics for 3 days, 5 days or 7 days kind of thing. But we need to make that part of a general conversation.
Mm-hmm. That's an interesting point. Yeah. So maybe since we're coming towards the end and thinking about take-home messages, is that one of your take-home messages for especially prescribers, or did you want them to walk away with anything else?
Well, it is a take-home message, is to think much harder about starting medicines and how they're going to be stopped. Yeah, particularly opiates. I think we've got much better at not initiating them. So other take-home messages, I think it's important to sort of recognise the benefit of deprescribing. Reducing somebody's pill burden, simply the sheer amount of tablets that they're swallowing can make a real difference to them and what's important in their life. When we've got people who are struggling to be enthused by eating, and yet we're putting 10 tablets down them every morning. Well, I'd rather you were eating your Weetabix than worrying about what tablets you were having. Do you see what I mean? And I think it's about getting some of those priorities right about what's important to you now. Yeah. The kind of the live for today element rather than, trying to bank your health for the rainy day. I think sometimes we've got to that rainy day.
Yeah. Yeah. So before I ask you for a question for our next guest, I wanted to pass on a question from Stephen Clark. So he had a question about where he said, when someone's reducing their medication, there can be withdrawal effects. Are there any key symptoms or contraindications to look out for, especially when trying to keep someone engaged in physical activity? Okay.
So there are withdrawal effects, and they're going to be made worse by a rapid withdrawal. So a withdrawal that goes too fast. So we're pretty cautious about how slow we go, in that, you'd be maybe reducing your dose by 20% per week or even per month. I think this is a really good question in terms of learning disability and introducing a completely new subject of STOMP, which is the stop over prescribing in learning disability, where we are encouraging physical activity. There's a lot of people with learning disability who are very mobile, very active, or we want them to become more mobile and more active. So when we reduce medicines in that group particularly, we do go very slow. It can take a year to wean somebody off a medicine that might have been started a long time ago to manage behaviours.
Mm-hmm.
And what we tend to find is that, yes, they might have side effects, but they tend to wake up and become more engaged. And that's actually the feedback we hear most often.
Fascinating. And I think that probably the message around thinking about the physical activity and reducing meds is actually we're reducing meds to improve their abilities. So we would expect them to do at least what they did before and probably more, wouldn't we?
Absolutely. Yes, I think we would. And, if somebody's not overly drowsy any longer, they've got more stamina. They can do more physical exercise. And that is really going to be the holy grail, isn't it? I think we really, really know that more exercise, more physical fitness, weighing the ideal weights for your height and size and what have you, are really the key things to better health.
Absolutely. And I don't want to put people off when we're talking about exercise, especially in the frailty. It's just about moving, isn't it? It's as simple as that.
Absolutely. And losing the ability to move is the thing that we should really, really work hard to hang on to. There's a great book by Atwell Gawanda, who's an American surgeon. He wrote a book a few years ago called Being Mortal, and it was all about that. It was his story of having to care for his parents, who had also been doctors and had been, very engaged and had fantastic, illustrious careers. But actually, it came down to him as a medic, realizing that getting his mum to the podiatrist was probably the most important thing he could do to keep her moving. Yeah.
On that topic then, have you got any other resources or recommendations for reading?
Well, there's a British geriatrician who is called Dr. Lucy Pollock, who's done some podcasts that you can Google and find her. She's also written a great book called The Book About Getting Older. I think this should be the Bible for us working in healthcare, but possibly it should be handed out to all of us as we reach about the age of 55, when we should be looking at, we're often caring for people who are getting older quite quickly, and also some of those foundation things that you can put into the whole of your health and social life that will help getting older. Yeah. She's a very engaging writer, and it's, it should, and the other people who should read this book is medics, early years medics, to understand where a geriatrician and where that older people medicine comes from. Yeah.
Oh, great. I'll put that on my list then.
Yeah, absolutely.
So if you let us know, we'll put that on the website as well, so people can find it easily. In our next podcast, we've got Keith Grimes. He's a GP, but he does a lot of work in the health technology sector. So he's talking about the benefits of AI and how it can improve health and well-being. What would you like to ask him?
Well, I really struggle with this question. I'm not necessarily that great on technology, and neither are care homes, quite honestly. So, which is where I work most of the time. And it's often difficult to get even carers engaged in AI. But I do think it's the future, and it's about how can we use it to help people understand their healthcare and the pathway they're on. We probably have lots more information now about if you've got these sets of conditions, when we were talking about the frailty index, and if this is your combination, the previous people have had this combination and this was their trajectory. So we have got that information there, but it's about how do we communicate it safely, kindly and usefully.
Thank you. I will pose that to him. I also get the difficulty. I'm a bit of a techie, so I like tech, but actually applying it in a really useful way is a genuine challenge, isn't it? When you get to the realities of the front line and the people be using it and things. So I'm looking forward to grilling Keith on that and see whether he's got any good ideas. Thanks for joining me. I think we'll draw it to a close, but it's been really fascinating for me. Thank you for giving us a good 50 minutes talk about deprescribing and frailty.
Thanks very much.
You've been listening to the Health and Wellbeing podcast about deprescribing and frailty with Kayt Blythin and me, Dr. Nick Harvey. For more information and resources, check out our website, sdhc.org.uk. If you have any feedback or suggestions for future episodes, please email us at sdhc.feedback@nhs.net. Tune in to our next podcast, where we'll be interviewing Keith Grimes on AI and how it can improve your health and well-being. Please take a moment to subscribe to help support us in supporting others with their health and well-being.